Absolutely. Thank you so much for inviting me to give this talk. I know this isn't a rare bone disease, but I actually do have some transgender and gender diverse youth who do have rare bone diseases, and I'm sure we'll be touching your practices as well as this population expands. So I'm very pleased to be talking to you today about this population, as well as the skeletal effects of the medical therapies that some of these youth may pursue. I have no disclosures, but all of the medications that we use for gender dysphoria or gender incongruence are used off-label. They're not FDA approved specifically for those diagnoses, which I think we're all quite comfortable with as those who care for children with rare bone diseases. And so today we'll talk a little bit just so everyone has the same foundation to work on. We'll talk about pediatric gender care, what it is, and actually, how do we deliver it? And then we'll also talk about, how do we even measure bone in DGD youth? What are the measures? What do the literature use? We'll talk about what bone considerations to keep in mind prior to treatment and then after gender-affirming medical therapy is initiated. I'll tell you a little bit about the research that I'm doing with my SEPSITY study. And then we'll go through some cases that are true to what we see in our clinics and what you might also see in your clinics. And then we'll hopefully have some time for some questions. So I'm just going to dive right in, and we're just going to start just with language. This is an ever-evolving slide. So just to make the point that there are two things that we talk about when we refer to individuals. One is the sex, and that is something that is often determined at birth. So based on either genitalia or chromosomes. And so a sex would be male, female, intersex as examples. And then gender exists sort of separately, again, sort of on a spectrum as we're learning more. And there can be binary genders, which are traditional, what we think of as transgender or cisgender, boys or men, and transgender girls, cisgender girls, women. But there's a growing population of folks who identify as non-binary, and they may use a variety of terms. These are just some examples, definitely non-inclusive of everything. And there have been different umbrella terms that have been used to describe folks who don't necessarily have cisgender, binary identities. And so these are some of the older terminology: gender nonconforming, gender diverse, gender expansive, or gender creative youth. Currently, I'd say the transgender and gender diverse, or TGD, is sort of the up and coming umbrella term that you might see in literature. So I will be using that throughout my talk. So just a background on the diagnoses we use. So currently we use gender dysphoria, which was recognized in the 2013 edition of DSM-5. And the definition of gender dysphoria is a marked difference between a person's expressed or experienced gender and gender others would assign, again, kind of usually dependent on genitalia and or chromosomes. And the dysphoria, the difference must persist for at least 6 months. If they're children, they must be able to verbalize this desire. So you have to be at least a certain age before fulfilling this criteria. And as with many DSM criteria, the condition must cause significant distress or impairment in functioning. So just to give a little bit more historical context, in the DSM-4, this was previously termed gender identity disorder. And in DSM-6, or the revision of DSM-5, this will now be gender incongruence, actually already available in the newest ICD-11. So just recognizing that children who are well supported may not have dysphoria and just have gender incongruence. And this now is sort of a developmental difference and not a mental disorder, just recognizing it's part of human variability. And so we'll be looking forward to that paradigm shift as it comes along. And in terms of, who exactly are we talking about? This is a very difficult population to provide accurate epidemiology statistics, but the UCLA Williams Institute has been trying to tackle this question. In 2022, they updated their estimated population of folks who identify as transgender in the United States. And for the pediatric population they've identified here, those who are 13 to 17 years of age, about 1.4% identified as transgender in the United States. And that this is a nationwide survey. So they do survey folks from every state of the country. And just to give you a little bit of context, in 2017, the last time they published a report, this was 0.7%. So it has doubled since in those 5 years. And in terms of in relation to what percent of the population those youth make up in the United States, it's much higher than their population. And the other thing to sort of note is that we see plenty of youth who are under 13 in our clinic. So, and those figures are not included here. So we're talking about a pretty sizable population, far more than the 300,000 that they're estimating here, because we have plenty of youth who are under 13. And then there's also the ethnic breakdown there for you. And then the other thing to also understand about gender-affirming care of TGD youth is just the history of how long it's been around. Here in the United States, the first clinic to describe multidisciplinary care of transgender and gender diverse youth started in 2007, and that's the Boston Children's Hospital Gender Management Service, the GEMS clinic, still in operation today. Here at UCSF, Dr. Steve Rosenthal treated his first pediatric TGD patient in 2009. And it wasn't until later that year that the Endocrine Society actually published their first clinical practice guidelines focused on endocrine treatment of TGD persons. Now that has been updated in 2017. And our Child and Adolescent Gender Center, as a multidisciplinary center, was formed just over 10 years ago in 2012. So it's a relatively new field and new population of youth who are undergoing medical therapy for gender incongruence. And for context, the first pediatric TGD patient was treated around 1997, and that was in the Netherlands. So they were the pioneers. And still, even though they predate us 10 years, we've only been doing this for less than 30 years. So long-term outcomes still unknown, but definitely an area of investigation worldwide. So what does the care of TGD youth entail? Ideally, we have a multidisciplinary team, just like our rare bone diseases. You will have some point people, some medical team, primary care, or pediatric endocrinology. All of these specialties can have expertise in care for TGD youth, depending on their training and what they seek out. And some of the youth may also have a mental health specialist, gender specialist, someone who is specifically trained in helping young people explore their gender, as well as gender embodiment goals, as well as help the family navigate the process. Social work and case management, also quite important. Legal aid, unfortunately, sometimes this is needed, and these days more than ever. Patient advocates can be helpful to navigate healthcare systems that may not be so friendly to making sure we use the chosen names and pronouns for our youth. Less of a problem these days in where I live in California, but school education and training is always something that we want to pay attention to for our youth. In those who have gone through more puberty, by the time they seek services, a vocal coach may be helpful for voice training. Down the line, we also partner with surgeons and fertility experts as our youth pursue other treatment modalities to bring their gender in alignment with their external appearances. And then dermatology as well are important for acne that may develop, or hair loss that may happen, or hair removal that may be desired. And so it's really everyone and the kitchen sink, and there's probably some other folks who may join the multidisciplinary team of care for these youth. There are many clinics around the country. This is missing some. I know that there's a great clinic in Colorado, and I always wonder why it does not show up on the Human Rights Campaign map. But just to say that, you know, I'm not sure that they still have this clinic map up, but it has evolved over time. And you can see that there are some areas that probably the clinics have closed now. But there are many across the country, and there are other clinics that may not have a full team, but still can provide care to youth, and sort of more upcoming, or a lot of telehealth services as we try to navigate a complicated political situation. So, you know, I can't do a talk about pediatric gender care without acknowledging that we're in a very challenging time for our care. There's growing legislature across the country banning or criminalizing pediatric gender care. It's been actually several years of laws targeting these youth. And so in the red, there are the red states, there are laws or policies banning gender-affirming care of pediatric patients, and there's a lot of sort of moving parts and things in the legislature. So it's made it a little bit complicated as we are starting to get out-of-state referrals. So on the positive side, there are more states that are becoming sanctuary states for pediatric gender care. So in the darkest blue, California being one of the states that have taken up the cause to make sure that we're able to provide pediatric gender care to any of our out-of-state refugees who are willing to travel or able to travel. So a little bit of a moving target, and something that we try to stay up to date on as we're moving forward. So how does the treatment approach actually work? So if you have gender dysphoria, and this is sort of really for insurance purposes, you have this diagnosis, then you can submit to the insurance team. I think about things in terms of your lifespan. And so in all of lifespan, mental health gender specialist may be helpful, may not be necessary, but in terms of helping to navigate the different transitions one may experience as they go along. Certainly prior to puberty, there's no medical interventions indicated. So here we do a lot of counseling, anticipatory guidance, supporting the families in any school resources they might need, communicating with their other family members, social transition. Those are the types of things that we talk about at this time. We also talk about what's upcoming so that people can start thinking about what the next steps might be. And for some of these youth, when puberty starts, Tanner stage 2 of puberty is the time when we can first consider puberty blockers with gonadotropin-releasing hormone agonists. Here we use either the depot injection, Lupron, or a hystrelin implant, which is a long-acting gonadotropin-releasing hormone agonist. At some point, gender-affirming sex hormones or gender-affirming hormone therapy is then introduced, and this we'll talk a little bit more in detail about timing of this, and that would be either the introduction of testosterone by topical, injectable, or pellet form, usually not to induce puberty, but these are the current options, and now there's a new oral form approved for adult patients, or with estradiol, typically with transdermal patch, but also can be with oral estradiol or injectable. And for some of our older patients or patients who aren't able to access gonadotropin-releasing hormone agonists, we may use spironolactone as an androgen blocker in conjunction with the estrogen-based regimens. At some point, some of our patients may pursue surgery, and that may be mastectomy or breast augmentation, or GU surgeries for vaginoplasty or phalloplasty or metoidoplasty, a variety of different surgeries. Some may just pursue hysterectomy. And then fertility preservation is something that we think about throughout the lifespan, of course, limited in early puberty and more of a consideration once puberty has started and gonads have developed enough to be able to preserve gametes. So just to say that when we look at the bone literature, I pay a lot of attention to where the study was done because there are two main approaches to gender-affirming medical therapy in TGD youth. So the Dutch, who were really our pioneers, who started this back in the 90s, they start gonadotropin-releasing hormone agonists after puberty starts. And we do the same thing here in the United States, and many other places may follow more of a pure concordant puberty timing model. In the Netherlands, they had started gender-affirming hormone therapy with testosterone or estradiol around age 16, and that's the age of majority in the Netherlands. So that's when teens could consent to their, make their own medical decisions. And they've now slightly inched that earlier to 15 years old. But if we remember the usual timing window of puberty, it's a bit late to be starting puberty if you've started blockers or gonadotropin-releasing hormone agonists at early puberty. And we know the consequences of delayed onset of puberty or delayed menarche can influence your bone health. And so at least in our clinic at UCSF, we have started gender-affirming hormone therapy by the age of 14, but often it is earlier these days to more mirror what a patient's peers might be experiencing in terms of puberty timing. We know puberty typically starts between 8 to 12 for those who have ovaries and between 9 to 14 for those who have testes. And so we try to mimic that window, granting that the youth and the family are ready to make those big decisions. So these are quite different models, and you might imagine that it could have different consequences on bone health. And so important to keep in mind. There are clinical practice guidelines, as I had mentioned. The Endocrine Society's guidelines were last updated in 2017, so they're a bit older, but the World Professional Association for Transgender Health, or WPATH, did recently publish their Standards of Care version 8. It's a very well-written and used a very rigorous process for their recommendations. So I'd recommend referencing those two if you have any questions more specifically about the evidence behind some of the recommendations. So before we go ahead, I acknowledge that we're not all pediatric endocrinologists, so I'll just talk a little bit about gonadotropin-releasing hormone agonists. They're also known as puberty blockers more colloquially. These medications were first synthesized in 1980. They're modified to have a superagonistic effect. So what we know is that gonadotropin-releasing hormone is a signal that is pulsatile and released by the hypothalamus, and then sensed at the receptor level at the pituitary, which then sends luteinizing hormone and follicle-stimulating hormone down to the gonads in order to stimulate sex hormones as well as gamete production. So what happens with the gonadotropin-releasing hormone agonists is that we abolish that signal and instead have a superagonistic effect and have a high signal, which then suppresses gonadotropin secretion from the pituitary gland, and therefore shuts down that hypothalamus pituitary gonadal axis. In 1986, that was when the first long-term study of gonadotropin-releasing hormone agonists was published, and that was used in the diagnosis of precocious puberty, and the duration of use was 2 to 4 years. They're also used in other conditions such as advanced prostate cancer, endometriosis, uterine fibroids, advanced breast cancer, assisted reproduction, and probably a variety of other things. But just to say, this is the mainstay of our kind of puberty blocking agent. And then before we discuss the bone considerations, I'll just review a little bit about how we assess pediatric bone mass. This is going to be a review for many of you, but just to say that DEXA, or dual energy X-ray absorptiometry, is the preferred clinical method to measure bone mineral content and aerial bone mineral density in children. The preferred sites are the lumbar spine and total body less head in growing children. The hips less ideal due to that period of rapid growth. And BMDZ scores are what we look at clinically. These are standard deviations from sex, age, and race ethnicity matched reference populations. And therefore, if you have a BMDZ score less than or equal to -2, you are considered to have low bone density. This doesn't mean that you have skeletal fragility, but it does mean that you're a bit behind when we sort of look at your age and sex matched populations. Now, I bring this up because there's no specific guidance on how to interpret DEXA in TGD youth. And the International Society for Clinical Densitometry, at their last position statement update, didn't really sort of go through recommendations for how to actually look at DEXA results in TGD youth. And so that formed the basis of one of the exploratory studies that I did with my research cohort. So we know that the ISCD doesn't have a position statement for how to interpret DEXA in pediatric TGD individuals, but they do have guidance for adults. And so in 2019, they did recommend that that they had some guidance on how to look at DEXA in TGD adults. Right now, our current literature basically calculates all BMDZ scores by sex designated at birth. So a transgender boy, they would really be looking at female sex reference ranges for the BMDZ scores, and a transgender girl, they'd be looking at male references to calculate their BMDZ scores. The ISCD actually recommends calculating BMDZ scores by gender identity, which is the opposite of what's in the literature. And for those who are non-binary, they recommend using sex designated at birth. Now, they don't really make a comment about looking at what the dominant hormone environment is and when they started gender-affirming medical therapy. So it's a little bit unclear where, how to assess bone mineral density. They also mention that you can kind of look at both BMDZ scores using both sex reference ranges if you're uncertain. There's also, for pediatric patients, no consideration of pubertal status or skeletal age in calculations, and we do know that skeletal maturation does slow down with gonadotropin-releasing hormone agonist therapy. So I know some of the height adjustment will take care of this, but nonetheless, what we did was that we explored 4 different methodologies using my research cohort, looking at bone density data and whether that might make a difference in your clinical interpretation. Not to say that there is one right way, but the first method, we looked at the sex designated at birth and the chronologic age, so their actual calendar age, which is what our current literature uses. So method 1 is what, if you read a paper, that's what they're looking at. We also looked at bone age and skeletal age. So we looked at the sex and skeletal age, calculated BMDZ scores of that methodology. And then we also looked at gender, chronologic age, gender, and bone age. And so what we found in our cohort of pretty equally divided sex designated at birth youth who were all in early puberty, Tanner stage 2 to 3 of puberty, primarily white and non-Latinx patients. What we found is that when we calculated BMDZ scores using the 4 different methodologies, we wanted to just look at clinical outcomes and, at least a clinical diagnosis of low bone density for age. There were slight differences, but not major differences in the small cohort. If we looked at our canonical sex and chronologic age, BMDZ scores, 11.8% of the designated female at birth transmasculine youth had low bone density for age, and 44.4% of the designated male at birth transfeminine youth had low bone density for age. These are quite high percentages if you think about what you might expect based on a normally distributed curve. So this we'll dive into a little bit more in our next few slides. And if you looked more on sort of the extreme other side, looking at gender and bone age, there were a couple more individuals designated male at birth who then dropped into the low bone density for age cohort. So there can be some differences based on how you calculate BMD-Z scores, and I'll be looking forward to new recommendations addressing how do we even interpret the data in these youth. Now, all of these youth, this is before they started any gender-affirming medical therapy, so it does make sense to look at their sex designated at birth, but once they do start hormones, then they would switch over based on the adult recommendations to looking at their gender references range. So it's a lot of confusion in how do we even interpret bone data in this population. So what do we know about bone before we even start any medical therapy? So what we do know based on several studies is that there's lower bone mineral density and bone mineral parent density Z-scores in designated male at birth youth. So those are transgender girls, transgender women, trans feminine, non-binary youth, than in those who are designated female at birth. Those are transmasculine folks, so transgender boys, transmasculine, non-binary youth. And that's before starting any medication. There was only one study that found the opposite, but these youth were at different stages of puberty. So not sure if this is something that we could really compare head to head in terms of populations here. But overall, there's a higher prevalence of low bone density for age based on DEXA, again, based on sex designated at birth and chronologic age. So in a couple of the studies that I have published, there's 30% of our trans feminine designated male at birth youth versus 13% designated female at birth transmasculine youth, and pretty high percentages in other sort of smaller studies as well. And you'll notice that, as I've reported up above, that it tends to favor or have higher percentages in our trans feminine youth. And most of these are retrospective, so we don't really have reasons why, but there have been some studies looking at negative and positive predictors of BMD-Z scores. So some negative predictors of BMD-Z scores: later age at timing of puberty blockers. Vitamin D deficiency is a negative predictor in this particular study. Some positive predictors: female sex designated at birth, with, as we know, the designated female at birth transmasculine youth don't tend to have as much low bone density. And then, of course, your vitamin D, kind of on the flip side, having a higher vitamin D serum, 25-hydroxy vitamin D, was a positive predictor. BMI Z-scores, the higher the BMI Z-score, the better the BMD-Z score. These are not sort of surprising to us based on what we know about bone health in general. And some associations that have been found, again, vitamin D, BMI Z-scores, but perhaps not statistically significant. And then other potential contributors: lower physical activity, inadequate dietary calcium intake. So none of these are very exciting or new, but I think important for those of us to take care of these youth to pay special attention to these particular factors that we could try to optimize as best we can. So the other thing to consider is when GnRH agonists are started. This is a Dutch study of 322 TGD youth, and they used some hip structure analysis software on DEXA scans at the start of gonadotropin-releasing hormone agonists and or gender-affirming hormone therapy if they started before the 18 years of age, so in the pediatric age range, and then after at least 2 years of gender-affirming hormone therapy, which again was started around 16 years of age because this is the Dutch population. They used hip structure analysis software to look at the subperiosteal width and the endocortical diameter, which I've tried to show you what exactly they're measuring here. And what they found was that TGD individuals had hip bone geometry metrics that resembled reference curves for the subperiosteal width and endocortical diameter the experienced gender when puberty blockers were started in early puberty. So the earlier you started, the more you would resemble what your affirmed gender reference curves would look like, which makes sense. You're sort of capturing things before the bone develops into their different curves. But if you started in mid to late puberty, you more resembled the reference curves of the sex designated at birth. So timing of gonadotropin-releasing hormone agonists can influence your bone geometry depending on when it was administered in relation to pubertal status. So this gives us some important clinical implications of skeletal trajectories and might help us to figure out how we're going to interpret DEXA scans in these individuals as they get older. So in terms of bone density changes on gonadotropin-releasing hormone agonist therapy, so we looked at the baseline pre-treatment bone density metrics that have been reported, and now we're on gonadotropin-releasing hormone agonists or puberty blockers. So what we know, and we know, some of this based on central precocious puberty literature as well, but in particular in the TGD youth population, bone mineral accrual generally continues. So you're still accruing bone, but it's at a slower rate. And because of the slower rate of bone accrual relative to age-matched peers, the bone mineral density and bone mineral parent density Z-scores decrease while on gonadotropin-releasing hormone agonist monotherapy, so not on any hormones. One of the groups, the Dutch groups, showed that the BMD Z-score decreases plateau. So you'll have a pretty stark decrease in the first 2 years, but from the 2 years to 3 years, there's a smaller decrease between those two time points. So at some point, there is that seems to be a nadir, and then gonadotropin or gender-affirming hormone therapy may be started somewhere after that. So we don't have much more time points beyond 3 years of gonadotropin-releasing hormone agonists in TGD youth, but that's sort of a function of when we typically start gender-affirming hormone therapy. So then what happens with gender-affirming hormone therapy? Generally, the addition of gender-affirming hormone therapy with testosterone or estradiol produces greater gains in the BMD Z-scores in TGD youth who initiated blockers earlier in puberty. So if you were in more Tanner stage 2 to 3 versus Tanner stage 4 to 5, there's a more robust increase in BMD Z-scores. But these studies have been short to medium term. So really only about up to 3 years in some. There haven't been any studies that have reported peak bone mass attainment after both blocker and or gender-affirming hormone therapy yet. And all longitudinal studies that have been published have been utilizing the Dutch approach. So again, blockers when puberty starts, and then gender-affirming hormone therapy around 15 to 16. So we're not going to have the data for the peer concordant timing model just yet because we're a bit behind in terms of when they started and when we started treatment. And the longest term study that has been published, and this was published back in 2015, found that our designated male at birth trans feminine young adults, and this population really started gonadotropin-releasing hormone agonists in later puberty. They were generally Tanner stage 4 or 5 when they started puberty blockers, and around 14 years of age, followed by gender-affirming hormone therapy at 16 years, found that the trans feminine young adults, so the trans women, had a further loss in lumbar spine bone mineral density Z-scores from baseline and then after gonadotropin-releasing hormone agonists, and the Z-scores fell further despite a median of 5.8 years of estradiol therapy. Now, this doesn't really track out all the way to peak bone mass, so I know that the Dutch group is preparing and waiting for the publication of their older adult population of this cohort of youth who are now in their 30s, and there's more promising data that have been presented at conferences. So we're anxiously awaiting the publication of that, of those findings. But it's not completely, the BMD Z-scores are not completely rescued to baseline, I believe at the lumbar spine in the trans women, even all the way out to age 30s. Now, we don't have any long-term outcomes, such as fracture information. Obviously, these youth are not that old yet. So people have tried to look at other things besides bone density. So just thinking about bone turnover markers as one of the little areas that people have dabbled in. There have been a few studies that have included measures of bone turnover. Now, of course, we know that bone turnover markers include markers of bone resorption and bone formation. And there's a lot of, this is dynamic period in pediatric patients where they are growing and going through puberty. What they found in the scant studies who have looked at bone turnover markers is that both markers of bone resorption and bone formation decreased after GnRH agonists. And because early pubertal TGD youth tend to have higher bone turnover, there's large decreases in that population. And in some studies, they've looked at bone turnover markers during the first year of gender-affirming hormone therapy. And in those, they found mixed findings in terms of which ones increase in which populations. And there were some increases in the first year of GAHT in early pubertal designated female at birth. So those are trans boys. And in the late pubertal designated male at birth, youth who are transgender girls. But they decreased again after subsequent 2 years of gender-affirming hormone therapy. However, as with all bone turnover markers in pediatric patients, it's really hard to interpret bone turnover marker data, and really more studies are needed, probably more time points over time. And, given the role of bone remodeling and development during growth and puberty, I think it would really be important to associate changes in bone turnover markers with growth potential and growth velocity going forward. So this is an area that people have looked at, but really inconclusive to date. Some other smaller studies have looked at bone marrow adiposity. So there have been a couple small studies looking at bone marrow adipose tissue. Now, bone marrow adipose tissue has an inverse relationship with bone mineral density and uses magnetic resonance imaging. Because it's so expensive, all of these studies are quite small. This first small case series had 6 early to mid-pubertal designated male at birth youth. So these are trans feminine individuals. Again, the population that tends to have lower bone density. They didn't find any correlations between DEXA and bone marrow MR variables in this particular study. In another study, another small study that had, again, 6 early pubertal TGD youth, here there were some designated female at birth youth and some designated male at birth youth that were receiving gonadotropin-releasing hormone agonists over the course of a year. These TGD youth were compared with 3 early pubertal cisgender female participants, and they utilized DEXA, peripheral QCT, as well as MRI. And they found that the DEXA BMD or BMADZ scores decreased in the TGD cohort, as we would expect on gonadotropin-releasing hormone agonists. And they also found that the trabecular volumetric bone mineral density decreased, while the cortical volumetric bone mineral density increased in the TGD cohort over that 12-month period of puberty blockers. They also found that there were larger increases in bone mineral adipose tissue indices in the TGD cohort when compared with the cisgender cohort. So there's some kind of early exploratory studies that might form the basis of future studies and give us more insight on changes in bone mineral adiposity during GnRH and GHT that we can't possibly detect with standard clinical DEXA imaging. But again, I think given the challenges and the costs of MRI, this may be limited to pretty small populations. But I think exciting that people are looking at this to get a deeper dive into what's happening at the bone level, because DEXA is such a crude estimation for us. So other advanced skeletal imaging techniques like high-resolution peripheral QCT or HRP-QCT can be utilized in this population. Again, very much limited to research. We know that the extreme CT2 has a resolution of 61 microns, so you can really see basically a virtual bone biopsy. But it can also give us insight into strength estimates. So aside from the bone microarchitecture, we can use microfinite element analysis to provide estimates of bone strength like stiffness and failure load. These things are not possible with DEXA or kind of our standard clinical imaging modalities. So this is a sort of an exciting way to look at bone in the absence of hard outcome data like fracture. So we did a preliminary analysis of the same cohort that we did our DEXA study on of 34 early pubertal TGD youth who had DEXA and high-resolution peripheral QCT at the distal radius and distal tibia. And we did find that low bone density was associated with lower bone strength. We have further data hopefully coming soon, but we did present this at ASBMR. So there are some correlations to strength when we find low bone density in DEXA. And so just to summarize, prior to any treatment, TGD youth have higher prevalence of low bone density for age. And some of the proposed etiologies for this baseline low bone density include lower BMI, vitamin D insufficiency or deficiency, lower physical activity, and later age at time of gonadotropin-releasing hormone agonist initiation. We also know that timing of GnRH agonists in relation to puberty is important in the development of skeletal geometry. And we know that GnRH agonists decrease BMD-Z scores, but bone mineral accrual continues just at a slower pace. Gender-affirming hormone therapy generally increases the BMD-Z scores, but longer-term studies are needed to really determine what peak bone mass is attained in these youth. And there are MR and other advanced skeletal imaging techniques that are in the works, hopefully providing more information about bone marrow adiposity, bone microarchitecture, bone strength differences and changes over time on GnRH agonists and GAHT. So there's some exciting things hopefully coming up ahead. And I'll tell you really briefly about my SEPSITY study, which stands for Skeletal Effects of Puberty Suppression in Transgender Youth. So my initial aims included trying to compare the BMD accrual by DEXA. This is just our standard in early pubertal transgender youth after 1 year of puberty suppression, matched with non-transgender youth. We also wanted to look at HRPQCT, bone microarchitecture, and strength changes, again, compared with the non-transgender youth population. And then we were going to do some exploratory analyses of all these other factors to see if we can identify risk factors for low bone density throughout the course of that 1 year of puberty blockers. Unfortunately, COVID happened, and we really were only able to recruit the transgender arm of our study. So we ended up with mostly our TGD youth. Our population was 35, and we were able to recruit some siblings, but only 5 of them. So really what we did was we looked at sort of the histories of our patients that included maternal and paternal heights to get some predicted heights, past histories, family history, fracture history, medications. And at baseline, we collected a lot of things, including bone turnover markers and other lab metrics, anthropometrics, pubertal stage, bone age radiograph, high resolution peripheral QCT, DEXA. We looked at grip strength. We also assessed dietary calcium and weight-bearing exercise using standardized measurements. At 6 months, we also did a high resolution peripheral QCT in case there were changes that were early on in terms of detection, as well as bone turnover markers. And then at 12 months, we just collected everything again. So this was after 12 months of puberty blockers. As of now, we've completed 35. We've completed our study, and then in total, we had 35 early pubertal Tanner stage 2 to 3 TGD youth who were starting puberty blockers. We only had 1 dropout, and that was because of needle phobia. They couldn't go on with puberty blockers or blood draw. Everyone completed study visit 1, 34 completed study visit 2, and 34 completed study visit number 3. And I'll say that I think we had such a wonderful retention rate. Our families are really interested in helping to advance the science. So it's been very gratifying to work with these families and youth. And most participants express interest in participating in future studies as we go on to think about what happens with gender-affirming hormone therapy. As I've identified physical activity being probably a large factor in the low bone density that we've seen, we piloted accelerometers on some of these youth, and so 10 of the participants also completed 7-day wear of active PAL accelerometers, so we can look at those data as well. And I mentioned previously that we did look at high resolution peripheral QCT results and presented this at ASBMR a couple years ago. And so these were some of the negative and positive predictors that we found. Low areal bone mineral density was a negative predictor of cortical area, cortical thickness, and failure load at both the distal radius and distal tibia. So there is some correlation when we find low bone density on DEXA, it likely translates to lower strength estimates. At the distal tibia, low bone mineral density was a positive predictor of trabecular area and negative predictor of total BMD, trabecular BMD. And we also found that the non-dominant grip strength was a positive predictor of total area and failure load at both sites. It's also a positive predictor of the cortical area at the distal radius and a positive predictor of trabecular area at the distal tibia. So this sort of muscle strength may be another area to explore. As we would expect, male sex designated birth, remember those are trans feminine youth who have lower bone density, have some correlations with HRPQCT data. Another sort of surprising thing that we found was that the age at social transition was a negative predictor of failure load at distal tibia. So unclear if there was longer duration of gender dysphoria or something that impacted that, but the earlier that you might socially transition, the possibly better outcome you might have in terms of a strength estimate at the weight-bearing distal tibia. Now, what's not on here, which was surprising, is that physical activity was not on here. The grip strength was, and so our hypothesis is that perhaps there's something about accumulated physical activity that translates to a higher muscle strength that could be at play here in terms of bone density and bone strength. The next steps, very excitingly, I recently received a K-23 to continue my SEPSITY study for an extension 3-year follow-up study. And so these will be for the youth who actually then decide to go through pure concordant puberty timing. So some of our youth may decide after a period of puberty suppression that they, that after exploring gender may stop their puberty blockers and undergo their sex designated at birth puberty. And so not all of them are eligible to continue on because not all of them continued with gender-affirming hormone therapy. So we will plan to recruit at hopefully 30 of the 35 who do initiate GAHT in the pure concordant puberty timing model. We will look at those bone measures again over the course of 3 years of gender-affirming hormone therapy. In addition to hand grip strength, we will also look at isometric knee extension dynamometry to get a sense of muscle strength in the lower extremities, that weight-bearing extremity. And then instead of just a questionnaire about physical activity, we will actually have a thigh-mounted triaxial accelerometer, that active PAL, mounted quarterly, so we get seasonal differences. And then we'll still have our dietary calcium intake questionnaire. So I'm really excited. So in the coming years, we should have more information there. I'm going to switch gears and just talk through a few cases here that may be helpful. And these are not specific patients, but just patients, cases that are representative of some of the patients we might see in our clinic. This is a 10-year-old male person who uses pronouns he, him, designated female at birth, who has neurodiversity or autism spectrum disorder, who presents with worsening gender dysphoria due to breast buds that began to develop several days ago. Parents have been supportive, and the patient has actually seen a gender specialist for several years. Gender has been consistent and persistent since he was 3 years old. However, he has a very restrictive diet consisting of processed foods and nearly no dairy products or vegetables. He can't participate in sports because it's too stimulating. He spends most of his time engaging in pretty sedentary activities. So how would you advise the family about next steps and sort of the things that we think about? This has my antenna up for potential low bone density. A lot of the patients that I see in clinic who have low bone density are on the spectrum, and we do know that there is some intersection between gender incongruence and neurodiversity. And so we do have quite a bit of patients in our clinic who have autism. And so trying to support, obviously we will be checking for bone density. There's no question that this patient has gender incongruence. This is one of our very classic, since a young age, has had a consistent gender. There's already a gender specialist in place. And so puberty blockers would be the next step, most likely, and we'll want to pay extra special attention to bone health with baseline DEXA imaging, making sure that we're vitamin D replete, potentially recommending calcium supplementation if there's not much, sounds like not much in the diet, they can find something that he's willing to take. And then trying to be creative about what kinds of weight-bearing exercises he might be willing to participate in to optimize bone health. So someone I'd really carefully talk through the risks and benefits of puberty blockers, and might be monitoring bone density more closely as we go along. So that's case one. Case two is a 17-year-old transmasculine person who uses he, him pronouns, who is designated female at birth, presents with supportive parents to establish care. They've been seeing the community previously where someone had put in a puberty blocker, Hystrelin implant, over 4 years ago to suppress menses before they got lost to follow-up. And he says, like, it's still working. I still don't have any periods. I've had this blocker in since I was 13. He hasn't had any skeletal imaging. He's now thinking about starting testosterone. How would you advise this patient and family? So we definitely had patients like this walk into our clinic. I remember as a fellow, we had a 18-year-old who had had a blocker placed and had been there for 3 to 4 years. This is just to demonstrate that the implant, while FDA approved for 1 year, often can last for several years. And our implants, we typically change out every 2 years because they get a little hard to remove after the second year and in the third or fourth years. But this person, I'd be very worried about low bone density. And a similar patient to ours did have quite low BMD-Z scores. And we definitely would want to advise either if he is ready to start testosterone as soon as possible and or remove that implant as soon as possible so that we can get some important sex steroids to the skeleton. So this can happen, unfortunately. Case 3 is a 15-year-old non-binary trans feminine person, pronouns they, them, who's designated male at birth, who presents with their supportive parents to discuss options for gender affirmation. They're very dysphoric about facial hair and genitalia, and they want softer features, but they don't want breast development. They just recently came out, haven't established care with a gender specialist or therapist yet. How would you proceed? So we see patients like this as well who kind of want a menu of things, and there's no way for an estrogen-based gender-affirming hormone therapy regimen doesn't produce breast development. I know there are often people who chatter about potential use of SERMs. It's not something that's recommended. There's no evidence for it, and we worry about bone health. This is a 15-year-old, so we wouldn't be recommending puberty blocker monotherapy, just given the risk to bone health here. And since it seems that they're just sort of new and in their journey, here we would recommend talking to gender specialists in more detail about gender embodiment goals and other options, and really having a frank discussion about what we can do and what we can't do with hormones and how to proceed with as little harm as we can. So here I might recommend if they don't want breast development, there are things that you can do that are potentially non-medical to help with some softer features. Or if you pursue androgen blocker with estrogen, you might just have top surgery to remove the breast tissue if everything else is okay. Here it's sort of a explore what we're really after for gender embodiment goals. So this last case, this is a 17-year-old male person uses he, him pronouns, and was designated female at birth, presented with his parents to establish care. He's extremely dysphoric about his chest and menses and desires gender-affirming hormone therapy with testosterone. He has found out that if you withhold calories, you can stop menses, and is now in a partial hospitalization program for his eating disorder. His parents are absolutely not willing to sign off on medical interventions, but will support kind of mental health therapy support. So how would you approach this family? How can you harm reduce in this situation? You know, again, very common. We see a lot of eating disorders and disordered eating in our population, and expressly for the fact that it can produce amenorrhea in our trans feminine youth. We may see this as well, just because of body habitus and how that might align with what their gender embodiment goals are. And so, you know, here we have a robust eating disorders program. We do not withhold gender-affirming hormone therapy just because of eating disorders. So that's first order of business. Now, parents are not willing to sign off on that. Luckily, this person is 17, almost 18, will be able to make his own decisions soon. But in terms of harm reduction, you might offer menstrual suppression options, and then just sort of explore with the parents what their reservations might be, et cetera. And this would be sort of a team approach with our mental health specialists as well. So very commonly seen, a younger patient is more challenging because they have a longer time to wait if the parents are not on board, but there are some things that we can help with. Sometimes families are willing to go forward with top surgery, but not hormones. And so just trying to understand what his goals are, as well as what the parents are willing to do. Again, it's not a small thing to start gender-affirming hormone therapy, so we never push anything, and we don't have any agendas. We just try to understand how we can best support the family and meet them where they are and help them get them all on the same page. So if you would like to read more about this, I have shameless plugs. I have recently published a review on all the current literature on both bone health and TGD youth. So if you want to look in more detail, all the studies that are out there, I have some tables that really kind of summarize all the different studies that have been published. And coming very soon, our next primer on metabolic bone disease and disorders of mineral metabolism. We will have a chapter on transgender medicine and bone, and I was fortunate to be able to help write this chapter with McCall Rothman, Charlotte Verroken, Chantal Whips, our Dutch colleagues. So there will be more to come that you'll be able to read about. I want to thank all the folks who have supported me in my journey in this area. And I thank you. And if we have time for questions, I'm happy to stick around.